Good afternoon, and welcome to the Maryland Women's Coalition for Healthcare Reform's webinar series, Leveraging Healthcare Reform, Cultural Competency and Health Literacy Strategies. I am your host, Sandy Kick, Health Policy Analyst with the Coalition. Today, we are excited to present this webinar, the fourth in a four-part series on cultural competency and health literacy, and the importance of both in our healthcare reform implementation efforts. Today, we will present health literacy, helping consumers get it, healthcare in an ACA world. First, we will hear from our speakers and then host a Q&A session before wrapping up today's webinar. Please note, we have muted all phones during our speakers' presentations, but will provide you with instructions for asking questions when we get to the Q&A portion of the webinar. Now, I'd like to introduce Lenny Preston, Chair of the Coalition, who will be both moderator and speaker today. Lenny?
Thank you very much, Sandy. And on behalf of the Women's Coalition, I want to thank everybody who joined us today. We have a broad section of individuals that are participating from private practices and hospitals to state and federal agencies to nonprofits in Maryland and in other states. So we hope that we hit the right level and that what we have to present today will be useful to you all. And also for your colleagues, I would note, as I will several times, the webinar will be posted on our website, mdhealthcarereform.org, and you'll be receiving an email about that, both the recording, the presentations, the recordings, and resources that you can reference later. I want to note, and again, I'll note this again, that we're going to save all of the questions for the end of the webinar, so you can write them down in the meantime. And for those that aren't familiar with the Coalition, just very briefly, we are a statewide organization of thousands of individuals and 99 organizations that work collaboratively to affect change in Maryland in the healthcare reform arena. And we do that by focusing on policy, legislation, education, outreach, advocacy, and action. And we want to thank our funders, Open Society Institute of Baltimore, and Raising Women's Voices for the healthcare we need. Our mission is, in fact, healthcare for all, and we look at that not just as access to an insurance card, but that's just the first step. Access to care that's comprehensive, high quality, and affordable, well-coordinated, and patient-centric. And in doing that we hope in Maryland that we can create a culture of health, and in that we can promote health equity. So one of the ways that we've been doing that work is taking our educational hat on, is this webinar series on leveraging healthcare reform, focusing on cultural competency and health literacy. And so our first one was actually almost a year ago. It seems impossible. And we looked at the big picture of defining the terms for both cultural competency and health literacy. In the second one, we broke it down a bit more, looking at consumer assistance and specifically Maryland's Exchange Connector program. And in the third one, we really took that to cultural competency and the providers. How do they meet the patient's needs? And I want to emphasize all of those webinars and all of the resources connected with those are, again, available on our website. So today, we're going to really take that to the next step and talk about the issue of health literacy and creating health-literate consumers. And I'm not particularly wild about health-literate consumers because I personally wouldn't want to be thought illiterate, but we can work on that definition too. We're going to look at how Maryland is implementing the Affordable Care Act and how we can leverage that to promote health literacy, define the terms, both health literacy and health insurance literacy, and talk some specifically about the impact of that and how we can address that through policy. So to look at the next step in all of this, we're very fortunate in having two dynamic speakers, Dr. Linda Aldoory and Dr. Izione Silva. And their full bios are going to be up on the website as well. Before I turn this over to them, I want to frame these issues a little bit within the context of what we are doing in Maryland. First, by creating a culture of health in multiple areas to improve population health and reduce disparities and reduce costs and improve patient experience and thereby create those health literate consumers. And one of the steps we've been looking at in looking at health literate consumers, one of the leverage points is, of course, the Maryland Health Benefit Exchange and its public face, the Maryland Health Connection. And I'm sure everybody on this call knows that March 31, fast looming, is the end of the first open enrollment period for the QHPs. You may not know that actually tomorrow is the deadline for anybody who wants to get coverage effective April 1st. Those who enroll through the 31st, their coverage will be effective on May 1. And then we'll have our second open enrollment on November 15th, by which time we hope our exchange will be working seamlessly. And on January 1st, the SHOP exchange will open. So one of the things that we've been looking at, everybody's looking at, is the numbers that have been coming into the exchange. And you may know that they revised our numbers downward on the projections. So the enrollment on the QHP side on the 1st of March was, as you can see, 40,693. Far more impressive on the Medicaid side, and a large part of that is that on January 1, those 95,889 individuals that were in the primary adult care program automatically rolled into Medicaid. So those numbers are looking pretty good. One area that we're looking at is making sure in the area of health literacy that as individuals go through the process of enrollment, they understand what it means to select the right plan. And we've produced informational materials in this that are being used by the connector entities, and more information on that, again, is available on our website. But we want to make sure that they are health literate enough to select the right plan by understanding what's affordable, what's covered and what's not, particularly with those who have special health needs and need to make sure that their provider is in network or that their drugs are covered under the formulary. So another area that we're looking at, a leverage point for health literacy, is the Medicare waiver. We now know it as the All-Payer Hospital System Modernization Proposal. Maryland was the only state which had a waivers that set hospital prices. And so for those of you who may be on the call from other states, I would suggest that you want to watch what happens in Maryland. And right now, they are in the process of putting meat on the bones of this proposal, but it's a 5-year model that's focused on improving health quality, delivery of services, and affordability. And it's going to put the hospitals under a global budgeting system with incentives to drive better outcomes at lower cost. So I'll talk a bit more about this in a moment. But the next tool that we're leveraging is the State Innovation Model, the SIM, which there are projects like this in other states. Maryland is focused on the Community Integrated Medical Home. We're waiting to see the final proposal on this, but it's an umbrella program with standards to allow for innovations across payers and to integrate the multi-payer medical home model with community health resources. So you can see that in the 4 pillars of primary care, community health, the strategic use of new data, and the development of the workforce. Another tool in the toolbox, I believe, for health literacy is the state health improvement process, which has been in place since 2011 and created a framework. They've just increased the number of measures in the 5 categories you see here, and the majority of those actually are related to health equity. And to leverage those and put them into action on the ground, there are 24 local health improvement coalitions, so that covers the entire state. And those are partnerships so that each community sets its strategic plan and identifies those measures that it's going to be working on in both the short and the longer term. There are other tools in the toolbox to leverage for health literacy, including Maryland's current 5 health enterprise zones and other projects that are similar to that are ramping up. There are opportunities in statute, such as the Cultural Competency and Health Literacy Education Law. But what I want to wrap up before I move on to Dr. Aldoory and Dr. Silva is the idea that all of these present opportunities for us as advocates for consumers to become engaged and to make sure that the consumer voice is at the table. So the Health Literacy Coalition that both Dr. Aldoory and Dr. Silva are aligned with, as is the coalition, they'll talk more about that, the local health improvement coalitions. Then there is a new standing advisory committee with the exchange. There are work groups for the Medicare waiver. There are task forces and work groups that will be put together for the state innovation model. So we need to keep these in mind as we're listening to Dr. Aldoory and Dr. Silva and see where each of us has a role to play. So now I'd like to move on to Dr. Aldoory's presentation. And let me say, again, their full bios are up on the web. Dr. Aldoory is the endowed chair and director of the Herschel S. Horowitz Center for Health Literacy and associate professor in behavioral and community health at the School of Public Health at the University of Maryland. Her research focuses on the role of health communication, and in particular for women and adolescents. She's been involved with the Prince George's County Health Enterprise Zone and a project with the Atlantic Hospital to develop health literacy curriculum for the Worcester County Public Schools, which we hope to highlight in our next webinar. She's consulted with the CDC, the FDA, the USDA. She's worked with the Maternal Health Child Organization and the American Psychiatric Institute. And today, she's going to look at health literacy. What is it? Why is it important? Give us the overview, and then explore how big the problem is and who it impacts. So just remember, we're going to take questions at the end, and Linda, I'd like to turn it over to you now.
Thank you, Lenny, and thank you, Sandy. I'm very pleased to have the opportunity to speak today about health literacy and some of its impact on health outcomes. I want to first encourage people to check out the center's website at healthliteracy.umd.edu. And please feel free to tweet. We have a Twitter feed at healthliteracy1. And in addition, any comments or questions after today can be emailed to healthliteracy@umd.edu. And on this first slide, you'll notice a picture. This is a picture of the center's namesake, Herschel S. Horowitz, so I wanted to add that there. And I wanted to add to what Lenny shared about my background and professional experience in health communication, that one fundamental lesson learned over all these years working in health communication, both professionally and in research, is the fact that there is this critical role of health literacy that plays throughout when we work in health, in effective, trying to make more effective health communication. The health literacy of the audience influences whether the health messages we're trying to create is received well, and these are health messages that come from doctors, organizations, media, government, and other sources as well. And a little over 2 years ago was when I became director of the Center for Health Literacy. And just for a second to tell you, the Center for Health Literacy's mission is to advance research and education in health literacy and health communication, and have that research translated into community programs that address the health literacy needs of different target populations. We have several community partners that we collaborate with on research projects. We have online courses in health literacy. We currently are doing a seed grant research program in health literacy. And today, as Lenny mentioned, I'm going to focus on sort of the Health Literacy 101 content of the webinar. So to start, what is health literacy? I want to actually continue first on a personal side and share a story with you to give you an example of what is health literacy and how it's affected my everyday life. A few years ago, my father was starting to lose his memory and his ability to walk, and I had assumed that it was Alzheimer's. Why? Because Alzheimer's was in the news, of course, a lot. It was part of health campaigns, and because many friends' parents had started getting Alzheimer's, so friends were sharing information about it. And with the assumption of Alzheimer's also came the assumption that it was not treatable and that Dad's decline was sort of part of the typical aging process. So several months passed and no alternative diagnosis was pursued. He was on certain medications, but we didn't notice that the side effects of those medications were making some of his symptoms worse. Not until Dad fell and ended up in the hospital did we discover that what he actually had was NPH, normal pressure hydrocephalus. The first time NPH was explained to us was by a neurologist, and it went something like this. Well, NPH is an abnormal accumulation of cerebrospinal fluid that causes the ventricles in the brain to become enlarged, sometimes with little or no increase in intracranial pressure. So here I was, an educated woman, lots of resources on hand, and I was intimidated to ask this doctor what all that meant. And I was faced with confusing information. I had to make decisions. And all of this information was actually supposed to help me understand, and yet I was more confused. Next slide, please. So this sort of shows how many problems can occur when someone is faced with low health literacy. And I wanted to ask if anybody else might have had problems with understanding, for example, side effects of medications and their dosage, with filling out medical forms correctly, with asking healthcare providers questions when they were confused, maybe being intimidated or just weren't sure what questions to ask, being uncomfortable sharing personal information with a healthcare provider, or having problems calculating the chances of getting a disease maybe once a family member gets a disease. And if anybody's ever had problems taking care of their own health, let alone the health of loved ones, be it parents or children. These are all examples of what people with low health literacy face in everyday life when dealing with health information. And I think, as this example shows, health literacy doesn't just affect people who can't read. It affects people with a variety of education levels and resources. So what is health literacy? Health literacy is the ability you have to find health information, understand it, make sense of it, and use that information to make health decisions. Health information includes health messages and medical information you see and hear from doctors, from the internet and television, from friends and family you talk with and might text with, and from apps and other technological innovations. It's not just the ability to read prescription labels and medical forms. While it does include that, it incorporates many more abilities as well. Traditional health literacy focused on the ability just to read medical information, but this has changed, and as Andrew Pleasant, an expert in health literacy, has said, one major change in the current understanding of health literacy is that it involves more than reading and understanding information. Health literacy is increasingly thought to include finding, understanding, evaluating, and communicating information, and using that information to make informed decisions. Now, with this new broadening of what is health literacy, though, comes layers of abilities, layers of things to think about, layers of sources of communication. And I think of these multiple layers as sort of a health literacy ecosystem of sorts, because when one of these layers is affected, it affects all the aspects of health literacy and all the parts that need to be addressed if you're trying to address someone's health literacy and improve health communication. So here's a list of characteristics that make up what I see as a health literacy ecosystem. First, that there's multiple senders, right? Information about a health issue comes from several sources. We already know this. And those sources, of course, don't always agree. So we get information, for example, about the Maryland Health Exchange from news, from friends, from healthcare providers, from the government itself, from websites and organizations. Second, these multiple senders are not differentiated any longer. There's a media synergy where sources blend and fuse, often creating new sources to add to our list of sources. Examples of this: Twitter, Facebook. You have a Washington Post article about how to access Maryland Health Exchange, which the article is using a Maryland government website as a source. So you go to that website, and that website is also then being tweeted by a nonprofit organization who picks up bits of information they think is useful to their audiences. And then an audience member picks up that information from the tweets to post on their blog or Facebook page, creating what you might think of as a health message, maybe soup. And then you have to kind of consider and make sense of all that, which gets to the third characteristic. Different people make different meanings from all of this soup. And that makes it challenging as health communicators to figure out what's the best way to communicate. And finally, while we are mainly talking here about intentional effects, where doctors and government campaigns are purposely trying to influence your knowledge and use of information, there are unintentional effects that happen. For example, when messages inadvertently make us feel inadequate, disempowered, or isolated in our health concerns. So as part of this ecosystem, there are several contexts for health literacy. The categories of sources for health information are multiple, but if we sort of summarize them, we get three groups: interpersonal, mass, and mobile communication, which is sort of a combination of mass and interpersonal. So we're looking at provider-patient communication, trainings that occur, communication from family and friends, small group communication and workshops. We have television still, magazines, internet, social media, but then we've also got our advertising, our media, our news, and then mobile communication includes apps and texting. So while I'm going to share some models and thoughts about health literacy, I'm really thinking about all of this together. So where is health literacy important? This is a kind of an interesting question, and I provide some of this data by request to show what's going on with health literacy in the different contexts or within different sources that are used for health information. Research has shown that provider-patient encounters are less frequent than other health-related situations that occur at home, at work, and in the community. Therefore, health information comes to us from many sources outside the healthcare professional setting. These other non-healthcare settings are not expert-based or based in the latest medical research, and thus, of course, often mediated through other people's meanings before they get to us. Similarly, the average person spends more time with media than with physicians in doctors' offices. Media here mean television, news, radio, and internet. And until last year, people in this country spend more time watching television than time spent with any other media, and that included internet or mobile phones. And this only changed last year where internet surpassed TV. So continuing to talk about where is health literacy important, this table is a bit hard to read, but it shows in general the time spent with major media by adults in this country over the last few years. And digital media, internet and mobile phones, for the first time in 2013, were more than television. When we look, but besides this, and the other thing you see in this table is that radio still has a bit of an impact, and print is significantly lower, and all others are also low. Under print, when they suggest newspapers and magazines, these are not the online newspapers. The online newspapers are above, included in the online digital media. In other research that looked at health information specifically, data show that almost 60% of U.S. adults look online for health information, and 15% of young adult cell phone users are using health apps. So in summary, where is health literacy important? These data suggest that television, online, and mobile phones are important sources to consider for better health communication and improving health literacy, and not just in the doctor's office. So what are the skills to focus on when considering improving health literacy? This model shows the different sets of skills included in community-based health literacy, where people are living their everyday lives and confronted with those multiple sources of health information, and not just when they go to a doctor. At the bottom are more basic skills needed first. The skill set that allows people the ability to seek information, which is the bottom left, includes ability to access information, ability to navigate and use the internet, and the ability to ask questions. On the right is the other base skill set to know where to find the right information. This includes skills in listening and reading and comprehension. These two base sets of skills then lead to better decision-making, which is in the center of the model. Here we hone in on increasing confidence or self-efficacy and critical thinking skills. And finally, these three sets lead to greater skills in communicating or sharing information, which is evidence of understanding and activity in wanting to advocate for better health. So why is all of this important? What are some general impacts of health literacy that create the urgency in understanding how and why to effectively design better health communication and increase health literacy? So this actually is a summary slide. Instead of going through each of these effects in detail, I just want to give sort of a summary of all of this and what happens when someone has low health literacy. And so research has shown that low health literacy leads to increased use of certain healthcare services, such as emergency rooms and hospitalizations. It leads to decreased mammography screenings and influenza immunizations, a poorer ability to take medications properly, later stage diagnoses with cancers and diabetes, and less ability to interpret health labels. People with low literacy are less likely to take preventative actions and have poorer overall health status, not to mention healthcare costs of up to 17% of all personal healthcare expenditures. And finally, higher mortality rates have been found among persons with low health literacy. So how big are these problems? How many people, in other words, are affected by these poorer health outcomes and higher mortality rates? So in a national survey a few years ago, they found only 12% of adults have average health literacy. This means that nearly 9 out of 10 people lack the skills needed to manage their health. 36% of Americans have only basic or below basic health literacy, and significant disparities exist in health literacy, where 41% of Hispanic Americans have below basic health literacy and 24% of African Americans have below basic health literacy. And in the same survey, they found that 69% of people who reported poor health had basic or below basic health literacy. Thus, the relationship between low health literacy and poor health exists. I'm going to quickly share 2 local cases of strategies that are attempting to improve health literacy. One is an organizational resource for their members, and one's a statewide voluntary effort. So the first one, American Health Insurance Plans, or AHIP, created a verbal health literacy toolkit. AHIP specifically geared this toolkit for their members, and their members are the health insurance companies in the nation. Now, I know everybody probably knows this, but health insurance companies, of course, rely on customer representatives. And even with all of the technological advances, in most cases, customer representatives are still answering phones and using the phone to enroll new customers, answer questions, and often settle conflicts, confusions of those with claims. And many of their customers who are calling by phone are from older adult populations. So AHIP wanted to create a kit that was unique in its focus on oral or verbal communication, not written, because most health literacy toolkits that we can find directly relate to how to write documents or materials, and there is also a toolkit on website health literacy, how to design websites better. But we were not able to find, and I helped AHIP with this project, we were not able to find any focused toolkit and resources that look at when you don't have anything written, you don't have anything visual, you're only using words verbally, how you can clearly communicate health messages. So the toolkit itself was very detailed and offered lots of sections of help. And the main audience were trainers of customer representatives, but also customer representatives themselves. Here, what you see on your screen is just a snapshot of a checklist of general questions to consider if you are a customer representative. This came at the end of the toolkit, and each of these questions had a section in the toolkit. For example, did you remember to ask the customer if they understood everything? Did you use the teach-back method? The teach-back method was brought up, for example. The second initiative I would like to share is Health Literacy Maryland. Lenny referred to this. Health Literacy Maryland was the brainchild of Alice Horowitz and Bonnie Braun, founders of the Center for Health Literacy. They wanted to create a community-based, voluntary coalition of advocates who either work in health literacy or who are interested in helping with health literacy across the state. The coalition creates ways to improve communication and is a collective voice of concern about low health literacy in the state. The coalition actually just had its first annual meeting just a few weeks ago, where over 100 people attended. And out of that meeting came certain issues that will be addressed in the future and 3 task forces. The issues that will be addressed include legislative awareness, cultural competency, clear communication, and professional resources, developing professional resources. And with 230 members thus far, the coalition is able to offer 3 task forces, one on membership and recruitment. This task force will look at continuing to boost the coalition itself and recruit new members to the coalition and publicize the coalition's good work. The second one is in policy engagement. This group will focus on legislative awareness and resources for not just policy makers, but also then information about legislation in a way that's clearly understood by 2 Health Literacy Coalition members. And the third task force is resources and information. And this group is trying to figure out ways to not just create better resources, but what resources might be needed, what gaps to fill in the information that's out there for professionals and others who are working to improve health literacy. And the picture on this screen is a picture of the newsletter that is sent to members. This is a former newsletter. And if you are interested in signing up as a coalition member, I strongly encourage you to do so. We're also now in the midst of developing a membership directory that would be only for members, and a benefit of joining would be to have the membership directory, and it includes across the state all the different professionals from various organizations that joined Health Literacy Maryland. And finally, the goal of Health Literacy Maryland, and really all of the work that the Center for Health Literacy provides, is to create health literate Marylanders who will seek accurate and useful health information, understand their health insurance options, ask questions of healthcare providers, be able to describe their symptoms clearly when they visit healthcare providers, calculate correct dosages of medicine, both over the counter and prescription, and we'll talk about health concerns with friends and family and ultimately successfully use healthcare services for themselves and for others. And I'm happy to take any questions at the end of this webinar and even after this webinar. Again, you can email me, you can email the Health Literacy Center, and if you'd like to join Health Literacy Maryland, also email me or the center. And thank you so much for listening. Lenny?
Thank you very much, Linda. That was terrific. I just want to note that the information about health literacy, there'll be links to that from our event page. And also on our resources, we will be sure that those AHIP materials are referenced. That's a great example. So thank you so much, Linda. And we'll get to questions in a little while. But first, I want to introduce Dr. Izione Silva, who comes to the field of health literacy after decades of personal and professional advocacy in the educational and healthcare sectors. And she's currently the Language, Culture, and Engagement Coach at the Disparities National Coordinating Center of the Delmarva Foundation for Medical Care. I usually say that the Women's Coalition has a very long name, but this one really tops it. So Dr. Silva previously worked in several areas, projects at the Primary Care Coalition of Montgomery County, and she's going to talk about some of those today. Prior to joining PCC, Dr. Silva held positions in the educational sector, including teaching English as a second language, Portuguese, and linguistics at the secondary school and university levels, and she also worked on World Bank missions in Africa. And for those who might require translation services, she's fluent in Portuguese, French, Spanish, and very conveniently Cape Verdean Creole, should anybody need that. So Dr. Silva is going to address what the impact of health literacy is on healthcare and the multiple and complex ways that health literacy can impact health outcomes. And she's going to discuss how we can best reach consumers and what our message should be. Before I turn it over to Dr. Silva, I want to make one important point. She has two really terrific video clips, and I'm going to apologize in advance because we've done our best to reduce the degradation, or as our IT guru said, pixelation. But this has to go through multiple systems. It reminds me of the complexity of the exchange. And so there's, as I say, some degradation, but the messages are so important, so we wanted to include them here. So, Dr. Silva, I'm going to turn it over to you now.
Thank you, Lenny. It is also a pleasure to speak to you today about boosting health literacy, a path to better outcomes. Next slide, please. In 2012, HHS leaders wrote that health systems often function as if all patients have health literacy skills and can be vigilant advocates for themselves. In reality, however, a wide chasm often separates what providers intend to convey in written and oral communication and what patients understand. Next slide, please. In the next 20 minutes or so, I'll provide a brief overview of health literacy, discuss the impact of health literacy on outcomes, share health literate care as a way to boost health literacy, and briefly describe a success story. Next slide, please. The IOM in 2004 defined health literacy as the degree to which individuals have the capacity to obtain, process, and understand basic health information and services needed to make appropriate health decisions. But as Dr. Aldoory has mentioned, the definition is much more complex. A 2003 federal survey found that over 30% of the U.S. population is low health literate, meaning that a substantial percentage of the U.S. population does not have the necessary skills to successfully function in the healthcare system. Now, most low health literate people are white native-born Americans who speak English as a native language, but the percentages with low health literacies are much higher among ethnic minorities, the elderly, those insured by Medicare or Medicaid, and the uninsured. 53% of the uninsured are low health literate, and as most of the uninsured become insured under the ACA, they will need assistance in using their newly acquired benefits to maximize their health and well-being and reduce costly use of the emergency department and hospitals. Keep in mind that the bulk of research focuses on individual literacy skills and demonstrating associations between literacy skill levels and health outcomes. But health literacy is based on the interaction of the individual skills with health contexts, the healthcare system, the education system, and broad social and cultural factors at home, at work, and in the community. Next slide, please. Moreover, the context of healthcare tends to negatively impact an individual's capacity. A highly literate individual, when sick and facing a poor diagnosis or prognosis, tends to have lower levels of health literacy. That is you and me. Next slide, please. We will now listen to how patients feel and what they often do in medical settings.
So just bear with us for a moment as we make the transfer.
I have a small breakfast, and then I take my pills. I usually take 16 every morning. Sometimes it's difficult for me to take these pills because if they say one tablet twice daily, I don't know if they're talking take one in the morning, one in the evening, or take one in the afternoon or one in the evening. So usually what I do is take 2 of them in the morning. Then this way I know I have them.
If you have a reading problem, you go to the doctor. That can be very scary. It's like a nightmare. You walk in that office, and mostly, if you realize, first thing you're going to have to do if that's your first visit is fill out a form. Your heart beats real fast. You're scared. You don't know what to do. You want to turn around and walk out. I have.
At approximately 30 or 31, I went into the gynecologist and complained about part of this not working correctly. And he said, we can repair that. Great. I didn't ask all the right questions. When I showed up 2 weeks later at the admissions office at the hospital, they put enough papers in front of me. I'll bet there were 5 papers that I needed to sign. Well, I wasn't going to say, excuse me, but I don't read really well, and I certainly don't read fast, and I'm concerned with some of these words. To me, it was lines and circles over sheets and sheets and sheets, and I wasn't going to reveal my sense of stupidity, so I signed everywhere they told me to sign, never read it, and then a couple weeks later in the follow-up office visit, the nurse said, how are you feeling since your hysterectomy? Now, I acted as normal as I could. Inside, my mouth fell open, and I thought to myself, how could I be so stupid as to allow somebody to take part of my body, and I didn't know it?
These patients do not understand. They are intimidated and afraid to ask questions. So it is crucial that providers not assume that patients understand what they're told. Patients don't understand informed consent. Patients have difficulty filling out forms. Patients don't understand how to take their medications. Patients are uncomfortable in the medical setting, and that discomfort leads some to walk out of cost-effective primary care encounters only to return seeking care in a costly emergency department. This slide shows the impact of low literacy on health outcomes, and Dr. Aldoory has already reviewed some of them, but you see that they have more chronic, people with low health literacy have more chronic conditions and make more visits to the emergency department, and they also have lower poor communication skills, and rate their health status as poor or fair. Next slide, please. Now we will look at some of these outcomes. Mortality rates. A clear correlation exists between inadequate health literacy and increased mortality rates. This study showed a 50 to 80% increased mortality risk for people with inadequate health literacy. Next slide, please. Hospitalizations and readmissions. In 2013, the Robert Wood Johnson Foundation diagnosed the U.S. healthcare system as having a chronic malady, which it called the revolving door syndrome at its hospitals. Too many patients are discharged from hospitals only to be readmitted soon thereafter. Some causes of readmissions relate to communication. Poor clinician communication, patients discharged without understanding their illnesses, without understanding their treatment plans, and without understanding how to properly take medications. Physicians caring for the patient who do not communicate with each other. Information about a patient's hospital stay that does not always go to the appropriate community clinician. These are all aspects of poor health literacy of the providers and poor health literacy of the health care system and of the patient themselves. Next slide, please. This slide relates the story of patients that illustrate this revolving door syndrome. Patients do not understand, do not ask questions, and are readmitted to the hospital, such as Eric, who left the hospital with a diagnosis of chronic pulmonary disease, but no understanding of when to use his inhaler. Or Barbara, who has type 2 diabetes, had to return to the hospital because her blood sugar was out of control. When she went home, she was no wiser about how to properly administer her insulin or eat properly. Next slide, please. With disparities, in regards to disparities, Healthy People 2020 provides a broad definition of disparities. This slide demonstrates strong associations between race, ethnicity, and educational attainment on the left column, and outcomes, the row on top. The outcomes are poor to fair self-rated health status and 3 preventive measures: flu vaccination, mammograms, and dental checkups. Excuse me. We can see in the top oval that in comparison with whites, a higher percentage of blacks and Hispanics self-report their health as poor or fair. Blacks and Hispanics also have lower rates of flu vaccinations and dental checkups than whites. However, that pattern does not hold for mammograms, where Hispanics have the highest rates and whites have the lowest rates. In the lower oval, patients with less than a high school education have the highest percentage reporting poor or fair self-rated health status and lower percentages in all 3 preventive measures. The authors of the study state that these findings raise the alluring possibility that improving literacy may be an effective mechanism to reduce health disparities. Next slide, please. This chasm of understanding is costly. In the U.S., we spend way more for health than most countries, yet we get least for our money. According to the National Academy on an Aging Society, poor health literacy have profound economic consequences. People with low health literacy use more health care services, and estimated additional expenditures due to low health literacy average about $73 billion in 1998 health care dollars. The 2004 IOM report acknowledges that although a robust estimate for the effect of limited health literacy on health expenditures is lacking, the magnitude suggested by the few studies that are already available underscore the importance of addressing limited health literacy from a financial perspective. Next slide, please. Up until now, I've presented a somewhat simple view of individual health literacy, measurement mainly based on individuals' capacity to read, oral communication, and listening skills, as well as the complexity of the tasks at hand, were not addressed. We cannot unravel the full complexity of health literacy, but look at the conceptual model in this slide. It considers patient level, provider level, and healthcare system characteristics that link health literacy to health outcomes. These individual and system-level factors fall into 3 areas of the continuum of care: access and utilization of health care, provider-patient interaction, and self-care. We will only focus today on access and utilization of health care, the large box on the top right. As for patient factors, with the ACA, many individuals and families are newly insured. They need to learn how to access and use health care in new ways. As a rule, only when people have a medical need do they seek medical care. People with low health literacy tend to delay initiating medical care. Some reasons may include lack of understanding of the benefits of prevention and or not having knowledge of early signs and symptoms of disease. One important caveat is that current knowledge on health literacy is based on studies in the medical setting. Few studies have captured the experience of people who remain largely outside of the healthcare system. Looking at system factors, the U.S. healthcare system is complicated and confusing. We have not-for-profit, for-profit, and government payers. And the most expensive plans have fewer barriers to care, and the least expensive plans have the most barriers. In addition, insurance plans cover medical, drug, dental, and vision benefits separately, if at all. Lastly, there are rule changes regarding what is covered, which doctors are in and out of network, as well as which drugs are available and when. No metric has emerged for how much the health disparity associated with health literacy might be due to the overall complexity of the healthcare system. Next slide, please. To bridge the communication chasm, healthcare organizations must adopt health literacy universal precautions, because everyone is at risk for not understanding, just as we have universal precautions for blood products. Since we can't tell by looking whether a patient is infected or not at the time of the encounter, we treat everyone as if they were infected. Likewise, since everyone is at risk for not understanding, we need to apply health literacy universal precautions to prevent misunderstanding and failure to communicate successfully. Next slide, please. The Health Literacy Universal Precautions Toolkit was released in 2010. It contains 20 easy-to-use tools in 5 categories. They are ways to form a health literacy team, ways to improve verbal communication, ways to improve written communication, ways to improve patient empowerment, and ways to link patients to needed community services. Next slide, please. The health literacy champion at the highest level of the Department of Health and Human Services, Dr. Howard Koh and colleagues, married this toolkit into Wagner's chronic care model to create this health literate care model. Designed for healthcare practices, this health literate care model infuses health literacy universal strategies, the purple oval in the middle, into the chronic care model. In Wagner's model, as in this health literate model, the entire care system is structured to support productive interactions, that is the yellow oval on the bottom, between patients and their providers. But how do you have productive interactions when providers assume that patients understand and patients, in fact, do not understand and are afraid to ask questions? Next slide, please. This slide shows how the 20 tools of the Health Literacy Universal Precautions on the left column interact with the various elements of the chronic care model, the top row. The vertical oval shows that 16 of the 20 tools apply to self-management support. Certainly, providing more self-management supports to patients will help them stay healthier and improve their health outcomes. Next slide, please. Let's now explore 3 tools from the toolkit that have the potential to boost health literacy and improve outcomes. 2 tools in the area of self-management and 1 in the area of community partnerships. Next slide, please. Tool number 5, Teachback. Although most health providers are aware of the Teachback method, few apply it. The purpose of the Teachback is to catch errors and misunderstandings. Could Teachback have made a difference to the woman on the video who had a hysterectomy and did not know it? The next time you are in Starbucks, notice how the baristas assure that you get your coffee the exact way you want it. Teachback is supported by research, and according to a 2001 ARC report asking that patients recall and restate what they have been told, is one of the 10 top patient safety practices based on the strength of scientific evidence. Next slide, please. So we've seen that patients are frequently afraid to ask questions. So along with creating a shame-free environment, healthcare systems and providers can encourage patients to ask questions. The Ask Me 3 program for the National Patient Safety Foundation encourages patients to ask and understand answers to 3 questions by the end of all medical encounters. What is my main problem? What do I need to do? And why is it important for me to do this? Next slide, please. Tool 18, Link Patients to Non-Medical Support, makes the case for healthcare organizations to partner with other organizations in the community to address the social determinants of health and assure better health for their patients. Social needs are the blind side of health care, according to a 2001 Robert Wood Johnson Foundation survey. 85% of survey physicians believe that addressing social needs is as important as addressing medical needs. Physicians say that social needs are access to nutritious food, transportation, and housing assistance. For example, at the healthcare practice level, Canadian family physician Dr. Gary Block and Associates prescribe for poverty. Health Leads here in the States is another model that relies on college student volunteers to meet patients' social needs as identified by a provider. At the hospital level, the Sinai Medical Health System, in Chicago, found that care transition to reduce avoidable readmissions means assisting patients with their social needs. For one patient, it meant getting the landlord to fix the elevator, assisting with transportation to doctor's appointments, and help with forms to move to another housing complex. The state of New York is now seeing housing as health care. Next slide, please. So in the next 2 slides, I'd like to share the experience of uninsured, low-income, low-health literate, and illiterate Spanish-speaking immigrant women who were successful in gaining an empowering perspective on their poorly controlled diabetes while also achieving impressive clinical outcomes.
Coming to this group, I realized that I'm not the only one who's struggling with the same things. Knowing that other people can do it makes me think and feel that I can do it too.
Right now, we are working with a group of 20 Latino women.
I have learned what it can do to my organs, to my heart, my liver.
Most of them are older. They live with their kids. They don't have the money to spend it for a visit. They rather pay for food or for things that their kids need. None of our patients have insurance.
Some of the women that come here, they don't even know how to read or write in their own language. That's very difficult in managing any disease.
Sometimes in this kind of population, they feel like the doctors have to talk and you just have to listen. But it's not like that. You have to ask if you don't understand something. If they tell you your level is now, what is that level? What is the normal level? What is the high level? Because sometimes if they hear it's okay with them.
Coming in for the first time, we didn't know each other. Having the same disease, and the same struggles have helped us to realize that we're not alone. I have formed really strong friendships. We call each other during the week to find out how we're doing, if we're taking our medication, how our blood sugar is. These groups help us realize that there's other people that are going through the same that we are, and making these friendships or making these connections is helping us live a better life.
These women also lowered their average hemoglobin A1C level by 1 percentage point. Hemoglobin A1C is a test that shows the average level of blood sugar over a 3-month period. It is the gold standard for management of high blood sugar among patients with diabetes. Next slide, please. In conclusion, we've seen that while health literacy is based on literacy skills, it is also influenced by education, culture, and interaction with the healthcare system. We've seen that health literacy levels are associated with health outcomes and costs. Those with lower levels of health literacy achieve poor outcomes and incur higher costs. We've also seen that health literacy levels can change depending on the health situation that each individual is facing. We've heard from 2 types of patients. One type very much afraid to engage with the healthcare system and advocate for themselves, and another type who get it, hopeful, engaged, and successfully meeting the challenges of chronic disease management and achieving impressive clinical outcomes. Therefore, I urge all of you to assure that all patients, including those who are low health literate, can feel comfortable in medical settings, ask questions when they don't understand, and successfully engage in the management of their health care. I urge you and your organizations to bridge the communication chasm by adopting health literate care model to boost health literacy, better engage patients, and improve outcomes. This concludes my presentation. This is my contact, and back to you, Lenny. Thank you.
Thank you so much. That was fascinating. And I particularly appreciate, well, all of it really, but the emphasis on the social needs and the connection of that with health. I think we need to do much more in that regard. So, but now I'd like to ask Zenobia if she would open this up for questions and explain how to do that. Zenobia?
Right. Hello, Lenny. I'll now officially begin our Q&A session. You all should hear an automated voice saying the Q&A session has started. So if you'd like to ask a question, first hit *6 to unmute your phone, and when prompted, press 1 to enter the question queue. When prompted to ask your question, state your name, organization, and question. Lenny and our speakers will provide answers to all of your questions. We will now begin the Q&A session. So if you have a question, you may hit *6 to unmute your phone and proceed.
Thank you, Zenobia. While we're waiting, I wonder if the two of you, Dr. Aldoory and Dr. Silva, could perhaps just give us 2 or three brief takeaway messages, things you want to make sure that those on the call, on the webinar today, remember when they leave us? Dr. Aldoory, do you want to go first?
Sure. I think one local takeaway message is that you are not alone in the work that we're doing in health literacy. I think as Izione and I showed, there are so many resources and initiatives going on. In particular, Health Literacy Maryland is a site to join and find out how others are challenged in the same way you're challenged, are working on the same things you're working on, and that together we can work on these health literacy initiatives and spread the improvements across whatever populations we're working on. And I think my second takeaway would be to understand health literacy as something outside the healthcare setting as much as inside the healthcare setting. So while some of our organizations may be focused on healthcare practices, and that's fine, if you are somebody who is in health communication or outside the healthcare practice, that getting into the community, getting into media, getting into campaigns, government partnerships with organizations, all of those are wonderful sites to consider when thinking of other ways to improve health literacy.
Thank you. And, that I was going to say this later, but the coalition is working with others on a conference for next fall as part of our health equity project that will bring together community leaders to provide tools to take back to their communities and do neighbor-to-neighbor outreach, focusing on consumer engagement and health literacy. So I think there, as you suggest, Linda, there are lots of opportunities here. Izione, do you want to give us your top two or three?
Yes. I think focusing more on the provider-patient interaction and relationship in healthcare settings, I think that's very crucial for providers not to assume that patients understand, because more often patients don't, and we've seen that a lot of patients are reluctant to ask questions. They are intimidated. Even Linda mentioned that she was, she had an issue that it was hard for her to deal with her dad, and so it's important not to assume, because patients don't understand. So it is crucial to use tools, some of which are in the Universal Precautions Toolkit, in order to assist patients so that they can better understand and take action. The other takeaway, I think, is what has been demonstrated by the Latina women in the Wellness Circles project. These women, most of them do not speak English, so you can even classify them as limited English proficient. But when they were provided with an educational opportunity that was respectful, that met their linguistic and their cultural needs, that created a sense of social support between them, that they really rose to the occasion. I mean, the amazing thing about diabetes education program is that a lot of times people say, oh, these types of patients cannot come, and the number of sessions are too many, but you do need quite a bit of sessions in order for the patients to be able to understand the information. And so these patients, they did attend these circles over a 7-month period, about twice a month. And what was amazing was that at the end, they wanted to continue because the sessions met their needs. So we can see that everyone can increase their knowledge, they can develop crucial skills, and they can feel empowered to successfully self-manage their chronic condition. And I think those are the two top takeaways that I would like to provide.
Thank you. I will spare you my own experience of low health literacy in a hospital setting, but I'm sure we've all experienced that as Linda did. Zenobia, have we got questions?
We do have a question.
Hi, this is Pat Medley from Baltimore Black Nurses Association. Got a comment and a question. The question would be, how do you decipher between people who are actually non-compliant and those who just have health illiteracy? That's one. And my question is, a lot of times with health professionals, many of my doctors do not know that I'm a nurse, and they actually take some shortcuts. And I just give you an example. We know that antibiotics are supposed to be given over pretty much the life of 24 hours, and yet they'll say take it 3 times a day and not explaining that you need to at least, have it so that it's spaced out. And I just also think that the other thing is how do you get people who really want to learn together and motivated to do that? And with the advent of health insurance now, is there anything within the health plans, I know for Medicare patients there is, where they could exactly get home visits? But I do believe that support programs would be really good for people who want to do the right thing for their health.
Let me just start that. I really want to turn it over to Izione, but on the thought of getting health to the home, so the state innovation model that I cited earlier with the community integrated medical home, that's one example of the kind of things that are being looked at in Maryland that would address the very issue you raised. But let me turn this to Izione first and then to Linda if she has anything to add.
I think I would not try to make a distinction between compliance and low health literacy, because as I try to emphasize in my talk, we are all prone to have low health literacy because the context of medical care is a stressful context. It's a stressful situation. So that a lot of times people are doing the best they can. Think back to the woman in the video who, was she non-compliant because she was taking all her pills at once? She was certainly trying to be compliant. She was certainly trying to do what she needed to do. So she took all her medications. So if you're looking at it, she's not being compliant, but she's certainly trying very hard. So I would try to find out why someone is not either whether the lab values, if they're not showing improvement, if the person is taking the medication, then should show improvement. If the person does not show, I would say dig a little bit further. Give the benefit of a doubt to that patient and try to find out, one, how they're taking the medications. Two, to also see what other factors may be, other factors in their lives that may be influencing their quote-unquote compliance. Because it could be that maybe they don't have the money to buy the medication, or maybe they have to take 2 buses in order to get to a medical appointment, or they just could not get to fill a prescription, or they don't understand how the discharge plans. So I would probe a little bit and provide extra education and try to find out the reason for the so-called non-compliance and to assist patients with that.
Okay, after saying all of that, perhaps I really should have been a little clear, because I know all of the things that you just said, but we have a certain segment of people who use the most amount of the monies in the health system that, to some extent, after doing all the things that you just said, still seem not to be able to do anything about controlling their disease chronic processes. and that are back and forth in the hospital on a regular basis. And I've gotten it on both ends, as the home care nurse that did the teaching and the nurse that worked in the emergency room, too. So I've seen it both ways. So that's where I'm trying to get at, unless there's some psychological reasons, because they have the medications, they have the insurance, they've had the follow-up, they've had all of those things, and yet their chronicity and their exacerbations seem to increase. And in their interest of the disease
the only thing else, I would say probe further as to the reason. Recently at the Disparities National Coordinating Center, we had a webinar where an educator shared with us the non-compliance of a patient patients were not able to reduce their sodium intake and so forth. So they were doing, I would say, a lot of things to help these patients, but these patients, their sodium intake continued to be considerably higher than recommended amounts. It turned out that these patients lived in a rural area. They had no access to a supermarket. The only place where they could buy food was something like a Dollar General, one of these dollar stores. And when a healthcare provider, in a way, tried to shop in one of these places, she too was not able to prepare a meal that had reduced sodium intake. So sometimes there are conditions that we just don't know about, and we just have to continue to be persistent, give the patients the benefit of a doubt, and try to find out further. Maybe
so perhaps before going down this path further, we might just emphasize that these are the sorts of issues that, looking at the Medicare waiver, and this will be a narrow piece of it, but looking at the incentives that can be in place for providers to encourage appropriate behavior and reduce readmissions, that's going to be part of our dialogue going forward that health literacy will play into. I did want to see, Linda, if you had anything to add to that, and for Zenobia, if we have other questions in the queue.
Not much, given that I do come from a communication perspective instead of a healthcare perspective, except to suggest that I agree with Izione in perhaps looking at noncompliance and health literacy just as distinct concepts. So, like the caller said, what's the difference, or how do you address one versus the other? I think it's true. I think it's a versus. I mean, I think you can have, because I think health literacy is something that someone might have, and the reaction they have could be compliance or non-compliance. And so if you have low health literacy, or you're not understanding something, but you feel you understand it, or you think you understand it, and you're going to purposely do something, that could be a reaction from low health literacy. Or a different reaction could be, I don't understand and I'm just going to shut down, or I'm just going to try things and then be wrong. But I do think by considering the two concepts separately may be helpful in thinking about how to first address the literacy issue, health literacy issue, and then maybe addressing the compliance issue separately.
Right. Thank you. And Zenobia, do we have other questions in the queue?
We have no more questions in the queue.
Okay. Shall we give you all one more chance for a question? Speaking to our listeners. Okay. Well, let me, first of all, thank you, Linda and Izione, for those really terrific presentations, and how it's great that others will be able to access those and access the resources that we'll put up on mdhealthcarereform.org. And I also want to thank Sandy Kick for putting the webinar itself together. And encourage everybody to stay informed and involved with the coalition. So I would encourage anybody who's not a member of the coalition now to join, and that way you'll be sure to get information about our next webinar. I would also encourage individuals to send us their stories, because those are the most valuable resources we actually have. Last week, somebody who couldn't get through our exchange enrollment system emailed me, and that's generated some good outcomes, including the fact that she got an insurance card. So send me those stories. And then there are a number of just resources that we want to make you aware of, including access to the webinar. And on the next slide are the links to the Maryland Health Benefit Exchange if you're interested in what's going on with the exchange itself and the administration. There are a number of opportunities to provide public comment on areas like fair hearings, and we've just, actually the coalition and others have put in comments on plan certification standards. The Maryland Health Connection, that is the public site for enrollment, and don't forget that anybody who needs coverage on April 1st needs to get enrolled tomorrow, no later than tomorrow. And then for those who are interested in what's happening on the federal side of things, the CMS site in particular, the marketplace.cms.gov, is useful. And on the next slide, our next webinar will be the actual taking what we've heard from Dr. Aldoory and Dr. Silva and looking at some very specific tools and ideas that people can use on the ground to help create health literate consumers. So we will be getting the information out about that very soon, and we anticipate that will be within the next month or so. So I want to thank both Dr. Aldoory and Dr. Silva in particular, and Sandy and Zenobi and the others at the Coalition for their great work. And we'll look forward to having all of you join us on our next webinar. And if you have questions, feel free to contact us, and we'll look forward to talking to you soon. Thank you very much. Have a great afternoon. Bye-bye.